Please give a warm welcome to our 2017 Charles T. Daughter Lecturer, Dr. Michael D. Darcy.
Well, first of all, I'd like to thank Chuck Ray for selecting me for this honor. I mean, it is truly the highlight of my career. I would also like to, similarly to what was said earlier, thank the FSIR staff. I mean, it's really because of them that working with the Society for so many years has been so easy and so fun. I need to acknowledge Kurt, Willie, and Dave. These were my mentors during my fellowship, and these are the guys that molded me into an IR. But most importantly, I need to thank my wife, Sue, who's here in the front row. I mean, she's been trying to civilize me for the last 37 years, and without her love and support, I would not have gotten here. So thank you very much, dear. So this stage of the lecture it's typical to say a few words about Dr. Doddard since we're honoring him. And I'm going to continue that tradition because it became apparent to me that some of the fellows are really losing sight of the people that really made our specialty great. And the way I discovered this was this year and last I gave our fellows a quiz. And I basically gave them a list of people, and I asked them to identify, the interventional radiologists out of this group with a few somewhat similar sounding names. And unfortunately, if you look at the results here, aside from a few top names, they really didn't know a lot of the people that made massive contributions to our specialty. In fact, when you get down to like Tegmeyer and Gian Turco, only half the fellows knew who they were. Now, I didn't see Ernie yet in the meeting. I don't know if he's here, but the good news for Ernie Ring is 100% of my fellows knew who you are. The bad news is that 50% of them think you'd already passed on. And then I also want to thank Fred Keller because he provided me the slides of Doddard. Fred was fortunate enough to have actually worked with Doddard. And for those of you who have not had the joy of meeting Fred, this is what Fred looks like. So Doddard, as was mentioned, is acknowledged as the father of interventional radiology. He was chairman at Oregon and received many awards and prizes throughout his career, including being nominated for the Nobel Prize. And he was a very innovative person who developed many of the tools and techniques that we use even today. And as was mentioned, most famously, he conceived of and performed the first angioplasty in 1964. Now, interestingly, when I asked Fred about Doddard, the teacher, he said that Doddard was actually a little bit too impatient. But just looking at these slides that he provided, you can't just help but imagine that he wasn't passionate about teaching. And he was also not only teaching us how to do procedures, but how to totally rethink about angiographic procedures. So Joseph Roche, who is a giant in his own right, credited Doddard with totally initiating his interventional thinking. And then Doddard was also known to use some innovative and maybe even extreme techniques for teaching. In 1961, he was giving medicine grand rounds and talking about what you might learn if you had a catheter in your heart. And at one point during the lecture, he rolled his sleeve up to show that he had been standing there the whole time with the catheter in his heart. And he hooked it up to a machine and then continued to lecture while showing his own pressures. And I think as we move into the new era of interventional residency, we need to be just as innovative and passionate as Doddard was as we train the interventionalists of the future. So I titled this talk, Training in the Pursuit of Excellence, because I think now more than ever it's going to be critical that we produce trainees who are able to produce the absolute best technical results with their procedures. And aside from being the right thing for our patients, this is going to directly impact how they get paid and how many referrals they get. So you've already heard mention of MACRA, and this is the reimbursement process that's going forward. And fortunately, it sounds like FSIR is going to be taking the lead and helping to develop the benchmarks. But these benchmarks will be used to gauge how much you get paid. And there'll be about an 18% differential between those who fall above the benchmark versus those who fall below the benchmark. So a considerable difference there. And then CMS is also interested in moving most of us towards alternative payment models, which is essentially bundled payments for disease states. And so I asked Zeke Silva and Kathy Kroll, two of FSIR's greatest experts on economic issues, what the implications of this were. And Zeke said, those with great expertise who can get great outcomes more cost efficiently will be a more valued member of the disease-based team. So in other words, the better you are, the better your results, the more referrals you're going to get. And Kathy said to succeed in this environment and to compete with others who also want to do procedures, IR needs to be the best. So in other words, if you're in a situation where you're competing against a vascular surgeon, a cardiologist who does the same procedures, that maybe finally having superior technical results will actually lead to you getting the referrals. And others, such as the advisory board, have also noticed the benefit of working with interventional radiologists. In this paper here, they were doing a report talking about longitudinal costs per procedure episode. And what they did was they compared the procedures performed by us, vascular surgeons and cardiologists, the same procedures, and the associated costs. And they found that we were able to do these procedures with about a 7% cost savings. And another interesting thing of this paper was they noted that the in-hospital mortality was 19% higher when it was done by a vascular surgeon. So we can definitely offer improved cost savings with our procedures, but it all depends on us having good technical results. And it's pretty clear that if you have poor technical skills, you will ultimately end up causing higher costs, either through complications, unsuccessful procedures, or inefficient procedures. And the new systems that CMS is putting into place will likely identify those providers who fall under the bar. So we've heard ever since Dotter that clinical skills are critical for being an expert IR. We've heard in recent lectures that you have to be an innovator and a competitor, but clearly your technical skills are going to remain one of the pillars of being an expert. So what are some of the attributes of being an expert or being excellent in IR? And this is a list of some of the, excuse me, I'm just getting over a cough and I'm trying to get through this lecture here. These are some of the attributes that I came up with when I was just thinking about this. And they match pretty much what you see in the literature when people are researching expertise. But there are a few things that come to the forefront in a lot of these papers that distinguish the expert from the average practitioner. And this is knowledge and attention to detail. And we're talking about knowledge. We're not just saying the expert has a little more knowledge. And people describe an expert as being having such in-depth knowledge that they can intuitively devise solutions to novel problems that would otherwise befuddle the average practitioner. And with attention to detail, people notice that the expert will frequently see details that the average practitioner will either recognize slowly or miss altogether. Now, these are two guys who achieved very high levels of success in their relative fields. And Booker T. Washington said, "Excellence is to do a common thing in an uncommon way." And what this means to me in interventional radiology is that even the simplest procedure can be done very poorly, or it can be done with great care so that even a simple procedure can be a way of showcasing your excellence. A personal example for me is the simple nephrostomy tube change, one of the easiest procedures we do. And yet it's not uncommon after I do one of these, the patient will say, "Wow, that didn't hurt. How come it hurt the last time somebody else did it?" And then Colin Powell said, if you're going to achieve excellence in big things, you develop the habit in little matters. And basically saying you can't turn it on and off. You can't expect to just blow off the small cases and be sloppy, and then suddenly turn it on and be excellent in the big cases. So how do we go about creating an expert? And these are some of the factors that a lot of the research points to. And we'll first talk about practice. I'm sure many of you have heard of the 10,000 hour principle that Malcolm Gladwell talked about in this book, Outliers. And the basic premise behind this 10,000 hour principle is that people like Mozart, Bill Gates, the Rolling Stones, all of whom seem to have innate talent, in reality, they all had spent 10,000 hours practicing their various crafts before they really burst on the scene and became famous. Even Mozart, who appeared to become very famous at a very early age, had put in decades of practice before he really got famous. So how does this pertain to the IR residency? Well, this is going to be an opportunity for some increased practice. First of all, in the current fellowships, we have to log 500 procedures, but in the new residency, the residents will be required to log 1,000 procedures. And there's also going to be more opportunities to both learn and practice clinical management of patients, both through more time on IR rotations, but also more opportunities to learn clinical skills in non-IR rotations, such as ICU. Now, it's important to recognize that regardless of how much time you spend during your residency, it's still going to be impossible to reach that 10,000-hour mark, and so learning must continue once you're out in clinical practice. Another way in which the residency may increase the overall level of our training of residents is by decreased variability. So currently there's a fair amount of case mix variability depending on what center you're at. Different centers have trauma, some don't, some are transplant centers, some don't. But bottom line is there's a lot of variability currently. And with the new residency, people are going to be required to submit case logs. There's a possibility that the ACGME may use this to develop some procedural benchmarks, and if they do, then this might allow them to identify programs that are underperforming in terms of providing adequate experience and hopefully raise the overall level of education. Now, simply practicing the same thing over and over again is not enough to make you an expert. In fact, one of the phrases that you'll see when you read some of this literature on expertise is that simply living in a cave does not make you a geologist. And so probably the next iteration of this is what's referred to as deliberate practice. And Erickson is one of the primary proponents of this. And this is practice that focuses on tasks beyond your current level of expertise. So deliberate practice involves first identifying areas of weakness. And so earlier in your career, this would be the job of the mentor or a coach. And then later in your career, this could be done either via self-assessment or, as we'll see a little later in the talk, via coaching as well. And then once you've identified these areas of weakness, you specifically focus on those, work on them in a concentrated fashion, and do so with intense concentration, what people refer to as deliberate thinking. Now, everybody that writes about this freely admits that deliberate practice is not easy. It's hard work. And Sam Snead nicely put this forth. I mean, he was one of the most famous golfers ever. And he said, it's only human nature to want to practice what you can already do well, since it's a hell of a lot less work and a hell of a lot more fun. Now, I will admit that deliberate practice by itself is not necessarily going to make everybody an expert. And there are certainly plenty of articles to the benefit of inborn talent. And this is one of those articles where they looked at world chess rankings, and they found that the #1 player in the world in 2014 had far fewer years of practice than those who were ranked far below him. However, in the medical education literature, there's a lot of articles out there that attest to the benefit of deliberate practice. One of those is this one from the anesthesia literature, where they randomized residents to either didactic teaching or didactic teaching plus practice sessions on intubation software. When they tested them all later, the group that had the chance to practice on the software did much better. And similarly, this is a paper from the surgical literature where they were having residents do laparoscopic cholecystectomies on a simulator. They then divided them up and had half of them do sort of traditional training, and then the other half, they did deliberate practice sessions, 30 minutes on a simulator, where they were specifically focusing on their weakest skills and trying to improve those. They would then be retested, and then they went through this cycle a few times. And what they found was that the group that underwent the deliberate practice sessions not only achieved higher levels of mastery, but did so much more rapidly. So can we incorporate deliberate practice into IR training? Well, I think, first of all, we would need to be able to identify the areas of weakness in the trainees. And when you look at skill-based assessments, techniques, most people say that the best way to do this is through the use of technical milestones. Now, we currently have some milestones that the ACGME developed, but none of them really are sufficient to allow us to really gauge somebody's technical skills. And I think we have some work to do in this area. I think another important part of this, particularly if you're talking about a big group like mine at Mallinckrodt, where we have 14 faculty, is communication between the attendings. If one attending identifies a weakness in a trainee and the others don't know about it, then when the trainee works with those other attendees, there are lost opportunities to work on those particular areas of weakness. Now, deliberate practice can potentially be done in clinical settings by steering trainees to specific cases that challenge their areas of weakness, or you could also have faculty do focused observations specifically looking at the areas of weakness and critiquing the trainees and trying to help them with that. A lot of the papers in medical education that talk about deliberate practice also talk about using models, phantoms, or simulators to achieve those practice sessions. And many of the other specialties have had great success with this. We have used simulators to some extent in IR, and I think we need to incorporate these to a greater extent in a more organized fashion. You can't simply ask a trainee to go play with a simulator for a while and expect them to get a whole lot out of it. These would probably need to be mentored sessions where the mentor can actually observe the performance and help guide their practice. And then I think as we move into an era where virtual reality is becoming more sophisticated, I could only anticipate that simulation is going to be a more important part of our training. In fact, it may also be a way for people already out in practice to either learn new skills or practice techniques that they don't do often enough to feel really comfortable with. Now, I mentioned deliberate thinking before, and that's something that everybody that writes about deliberate practice also talks about. And this is really the process of really fully engaging mentally in the entire practice session. A lot of times when they talk about this, they say you have to almost simulate mentally what you're going to do before you do it, and then fully engage in the process, including doing self-analysis and trying to figure out what went wrong, how to do it better. So how might this pertain to what we were doing? Well, if you're going to ask a resident to practice jugular venous access, for example, you wouldn't want to just have them stick a probe on and just keep poking until they get into the vein. You really want them thinking about all these anatomic and mechanical factors that go into making the technique either easier or more successful. There was a famous violinist, Nathan Milstein, who asked his mentor how many hours he should practice. And Professor Auer replied, it really doesn't matter how long. If you practice with your fingers, no amount is enough. If you practice with your head, 2 hours is plenty. And this basically attests to that same principle that you really can't just go through the motions with your hands. You really need to get the trainees to engage mentally in every aspect of their practice. Now, the other critical component of creating an expert that is written about in the research on this topic is the process of having a devoted mentor or teacher. And Professor Bloom wrote this landmark article a number of years ago, and what they did here was they looked at 120 elite performers in these various fields. And they then looked at their childhoods and tried to figure out what sort of common characteristics they had. And some of the things that you might think would be important, like a high level of IQ, actually didn't match across this entire group of elite performers. Instead, what they found was that intense practice and a devoted teacher or mentor were really the main key characteristics among this entire group. And if you look at guys like this, Tiger Woods and again Mozart, people who have long been viewed as having just tremendous innate talent. Well, if you actually look at their histories, both of them had fathers who, in their own right, had a fair amount of expertise and who started with their sons at a very early age and worked with them in a very intense fashion. So these guys, both of them got to where they were partially because of their skill, but in large part because of the mentorship. And some people are writing about, us faculty as more doctor-coach, and then the idea here is that just like a coach, you're going to observe the performance of a trainee during a procedure. You want to assess their performance and then provide what they refer to as formative feedback. So not just criticizing, but giving them feedback that allows them to figure out what went wrong, how to set goals for practice that will allow them to move beyond that stage in the future. The benefit of this technique is nicely demonstrated in this paper from Northwestern. In this article, they were teaching residents how to do effective handoffs. And what they did was, after testing them, they would put them through a curriculum that included deliberate practice with feedback from expert mentors. And then if they failed, they would cycle them back through the sequence. And what they found was that they started out with a group of residents who universally failed and did not meet their standard, and very quickly were able to move them all to a stage of 100% mastery of the skill. Now, it's also been noted that coaching may benefit people further out in their careers as well. There's a lot of research that indicates that if you simply do your job and do your same thing over and over again, you will achieve a certain level of expertise, but that over time your performance will not only plateau, but maybe even tail off. And the people that achieve truly high levels of expertise are constantly challenging themselves to improve, getting information from other people and coaches on how to change their practices, etc. Now, Atul Gawande published this interesting article in New Yorker, and in that he posed a question. He said, if top athletes need coaches and benefit from having coaches, why shouldn't we as physicians benefit from the same thing? And so what he did was an experiment where he hired a mentor, or an ex-mentor, one of the retired surgeons, to come in and basically coach him. This guy would come in, observe his operations, and then critique them afterwards and give him, suggestions on how to improve. And even though Dr. Gawande's, he was 8 years out from training at this point, he already had complication rates that were below national averages, and yet after the period of coaching, his complication rates dropped even further. So suggesting that there is some benefit to coaching even in our later years of our career. Now, he also, he also observed that, or admitted that not many people are going to go out and hire a coach, and he offered these ways in which we might potentially be able to achieve some degree of coaching out in our careers. First of all, hands-on skills-based workshops at meetings such as this are a way that an expert can potentially observe and critique your performance when doing certain skills. Certainly observing and learning from your partners is a way to learn new things and change your practices. And then you can have your partners critique your performance, either through live observation or review of videotape procedures. Now, I'm sure some of you out there are thinking, when the hell are we going to find time to do this personalized coaching of residents? And this author, Dr. Sweeney, posed an interesting solution to at least part of that. It's acknowledged by many people that lecturing is a really passive form of learning for trainees and really probably doesn't fully utilize the skills of the faculty giving the lectures. And so what they did in their institution was they replaced the lectures with web-based modules that the trainees would view on their own. And this freed the faculty up so that they had time to actually do some of these mentoring small group sessions. Another thing that I think we might want to think about is just our role. In the past, every faculty member was clinician, researcher, teacher, all rolled up into one. I think we need to recognize that teaching is a unique skill, and we possibly need to think about finding ways to free up the people that have that skill to teach, just like the people who are really good at research usually end up having more time to do research than others in your group. One of the other problems that we have is that most of us have never been educated on how to teach. This is a very nice article on deliberate practice in medicine, written by an anesthesiologist. And Hastings noted that only 10 to 20% of the faculty had any sort of formal education in teaching. So I would actually challenge FSIR to develop some programs to teach us teachers how to teach. And things that I think that we could be taught would be how to really objectively assess training progress, how to develop milestones that are meaningful, and how to provide feedback that really allows the trainees to set goals for their future practice. So I'm going to spend the last few minutes talking about some of my pet topics, just things that I like to work with the residents when we try to move them beyond a level of just basic competency. And hopefully maybe some of these will be a little more profound than Saturday Night Live's deep thoughts. But I want to start off by just saying I think anybody can be taught basic catheter work. And to demonstrate that, I'm going to introduce you to my granddaughter, Audrey, who is 6 years old. And in just a few seconds, you're going to watch her deploy a stent in this model we built. And hopefully she'll drop it off right where the Lego guy's pointing. Now, I will confess, I do think she must have a little bit of talent, because she obviously knows how to put on protective devices better than her brother there. So let's listen.
So we're going to have you drop that stent off in the artery, right?
Yeah.
Okay. So what I want you to do is I want you to hold this hand very still. Don't let it move, and then just pull this blue part back. Are you ready? Go ahead. Okay. I think you got it.
I see.
So there, yeah. So another budding future interventionalist. But so anyway, there you have, with minimal, coaching and no prior experience, she was able to drop that stent off. So, we obviously need to move our trainees so much, further beyond just, simple pin and pull, instruction, that kind of stuff. Now, while seemingly contradictory to what I've been saying so far, one of the things that I actually really like to work with the trainees on is really a detailed understanding of the fundamentals. Because really, in-depth understanding of the fundamentals is sort of the foundation upon which expertise is built. And it's also what allows people to evolve their practices. If you look at what I did when I was a fellow, we did leg venos and various kinds of arteriograms that we never do anymore because technology has moved beyond that. But at the same time, there are all these procedures that I was never trained to do, and now are parts of our daily practice. So clearly, I think an in-depth understanding of the fundamentals is what has allowed us to translate past experiences into new procedures. I also like to work with them on body mechanics. A lot of trainees, when they get up near the angio table, are like mannequins. They barely move. And if you look at the image on the left there, this is a resident putting a catheter in before a filter. And you can see by standing the way he has to turn his head to look at the monitor. He's pushing the catheter backhanded, all of which can be solved by simply turning his body around. I see a lot of residents who grab catheters underneath as opposed to simply grabbing it on top to push it in. And that significantly changes the angle and the resistance that they're going to encounter. And while most of the time that's not going to make any difference at all, if you encounter a very fibrotic groin or dialysis access, that could make a big difference. And then a lot of times I see people grab the needle with their right hand regardless of how they're positioned, and then if they want to move the needle towards the head, as in this jugular access, they're running into their other hand. I will oftentimes encourage them to switch hands, and many of them resist that because they say, I can only use my right hand. But I really strongly encourage them to learn to be ambidextrous. I actually had one of my ex-fellows just tell me last night at dinner that he found that to be a great skill. But anyways, that's something I specifically asked them to work on, and I practice myself. Ergonomics is something we really need to encourage the trainees to think about because I oftentimes see them leaning over like this. And when you're leaning like that while wearing lead, clearly that's got to be a contributor to the very high incidence low back pain that's seen in interventionalists. And I think as we move into the IR residency, this is going to be more important than ever. I honestly think that many of these people entering the residency are going to be really looking at lifelong careers in IR and not really planning on falling back on a diagnostic career when they start having aches and pains. So if we don't teach them how to protect their bodies, they may have career-ending injuries. Situational awareness is another pet topic of mine. A lot of times the trainees get up to the table and they're so focused on what's on the screen, they're totally oblivious to what's around them. And I think it's critical to make them aware that they have to be listening to everything that's happening in the audience, or in the room rather. So for example, if you hear the ectopy on the EKG, it's an opportunity to adjust your catheter before it becomes an arrhythmia. Or if I hear the nurse, walk up to the patient and she's not trying to disturb us, but she wants to very quietly ask the patient, are you breathing okay? That makes me look at the O2 sat monitor right away. And then they're oftentimes unaware of what's under the drape, sort of out of sight, out of mind. I'll see people put instruments on this part of the drape, and I have to remind them that the patient's face is right under there. And one sort of funny episode that occurred when I was at Minnesota, one of the co-fellows was doing an arteriogram, and he was telling me they kept like trying to smooth out this lump in the drape that was, you know, getting in his way, and only later did he realize he had been trying to flatten out the guy's penile prosthesis. And then the mental aspects of IR are critical as well. You know, if you read the literature on expertise, they say that a true expert oftentimes undergoes complete mental simulation before they even undergo a task, including contingencies. And so we need to talk about, you know, really thinking ahead. You know, it makes your procedures more efficient. It keeps you out of trouble with complications. And I oftentimes like to work with them on just dealing with what's necessary versus unnecessary motions. You know, I'll see a resident do something and I say, why did you do that? And I'll get a shrug of the shoulders and a sheepish, I don't know. And, you know, usually to that I will reply that every single motion during your case should have a reason behind it. And then I think it's critical that we, you know, instill in our trainees an attitude, a passion for what we do. I think that's going to what really propels them forward into the future, to learn more, to want to improve our specialty. And we do so many fabulous procedures, and we have such great toys to play with. How could you not be passionate about this specialty? I want you to listen just for a second to my grandson Logan when I showed him a stent for the first time.
Incredible. I like this.
Incredible.
Yeah, incredible. I mean, you know, if only all of our trainees could be that you know, fervent and passionate. And, you know, I'm not the only one that believes in this. You know, when Bob Lewandowski, our meeting chair, asked me about my topic, you know, he sent back this reply. I said, I have long believed that if you have passion for what you're doing and you are really good at it, there will always be a role for you. So I think, you know, if we are passionate and we, you know, really force our trainees to strive for excellence, to be the very best they can, you know, who knows, maybe one of our current residents will be the next daughter who totally transforms medicine again. We've had many great leaders in IR, and they've done a fabulous job of being innovative, you know, creating many new techniques and tools. I think as we move forward with this new paradigm of training, we need to be equally innovative and passionate as we train the IRs of the future. We need to be training the elite, the people that can provide the best, the most excellent interventional care with the best value. And while I never would have thought that I'd be, you know, quoting Kanye West during my Dade lecture, while I was researching this, I came across this quote, which I think is not only a great attitude, but I think it fits IR perfectly. And I think if we strive to really improve our own techniques and make sure that our trainees are the best technicians ever, then I think, like Kanye said, excellence will be the bare minimum. So thank you, and enjoy the rest of the meeting.